All right, welcome everyone. It looks like it is noon sharp, so we are going to get started. I will stop sharing my screen here. Thank you for joining. All right, let's dive in, everyone. Welcome, welcome. We are very excited to have you all here. I just want to make sure everyone can hear me okay. We're kicking off fine. Maybe just give a thumbs up so I can see. Yeah, thanks, Ryan. Okay, perfect. So if you are new to Zoom, do take a moment to find the chat box. That's where you can engage with your other colleagues, and we'll also put some content in there that you can go take a peek at later. We also recommend that you use the speaker view for this panel discussion. That way you can see the main speaker at any given time rather than a ton of people on your screen. So to do that, at the top right-hand corner of your screen, it should either say right now speaker view or gallery view. And if it says gallery view, just click on it and it'll change over to speaker view for you. So top right-hand corner of your black screen, just hover and hold your mouse there and it will tell you what view you're currently in. And try and get it onto speaker view by clicking it. Perfect. Feel free to turn your video on if you'd like to for the session. It is very nice to see everybody's beautiful faces with us today. That being said, it would be great if you could keep yourself muted throughout the duration of this session, unless you're speaking. I do have all the power, so if I need to, I can mute you all if you're not able to figure out how to do it yourself. But yes, do try and stay muted, and if you feel like turning your video on, it would be lovely to see you. During the panel discussion, you will have the opportunity to ask questions. You can do so by either using the chat function, which hopefully you found by now, or by raising your hand. So just above the chat function button area, you'll see yourself as a speaker, and there should be an option there for you to raise your hand. We'll come to you and ask you to unmute yourself to pose your question verbally if you'd like to do so. So for those of you I do not yet have the pleasure of knowing, I am Robyn Waite of Results Canada, and I have recently been supporting the Stop TB Canada network as a secretariat. As I'm sure many of you have noticed, we have been working really hard to rebuild the network, and this webinar is just one of many activities we were rolling out as to relaunch with a really big bang. So moving forward, you can expect to see us engaging regularly on Twitter, that's @StopTBCanada, hosting quarterly webinars, the first of which is this awesome one we have for you today, and releasing quarterly newsletters. If you want to learn more about our relaunch activities, you can check out the latest newsletter. I put a link to it in the chat function right now, so you can just click on that and learn more. So now more than ever, it is critical that as a community committed to ending tuberculosis, we share knowledge and information, pool our resources, and coordinate effectively to maximize our impact. So we are really, really pleased to announce that as part of our relaunch efforts, we currently have a call for expressions of interest for joining a Stop TB Canada steering committee live. So if you are a TB survivor, advocate, researcher, healthcare worker, or policy or program officer, we would love to hear from you and have you help build and steer the strategic direction of the network. Again, if you check out the link in the chat box in our newsletter, you'll be able to find all of the information, and applications are due August 31st. Please note that the commitment of time would be about 5 hours per quarter. So that's only 5 hours every 3 months. And that's because you'll be supported as a team by 2 secretariats, one of which is currently me in my post at Results Canada. Thank you, Results Canada, for allowing me to spend my time working on this. And also hopefully another secretariat from the McGill TB Center. We're currently in discussions with them to see if they're happy to come on board. All right, now let's dive into today's webinar, which is exploring the impact of COVID-19 on affected communities and TB programs at home and abroad. Dr. Dina Fisher, a co-chair of the Stop TB Canada Network, will be moderating today's panel discussion. And we have three great speakers with us today. Sharon Owlijoot, a public health nurse from the community of Arviat, Nunavut. Dr. Ryan Cooper, an infectious disease physician working in Canada to end TB. And Aamir Khan, a TB program implementer who's done work in Pakistan in partnership with TB Reach, which is a Development Canada funded initiative. So before I hand over to Dina, let's take a moment to have each of our speakers briefly introduce themselves. We'll start with you, Dina, followed by Sharon, Ryan, and Aamir. So Dina, please go ahead and unmute yourself to introduce yourself.
Hi, I'm Dr. Dina Fisher. I work in Calgary, Alberta, Canada. I'm the medical director at the Calgary Tuberculosis Clinic, and I'm a co-chair for Stop TB Canada.
All right, and over to you, Sharon.
Hi, my name is Sharon Owlijoot. I'm from Arviat, Nunavut, Canada. Our current lockdown situation here in Nunavut is that we've had a public health emergency since the COVID-19 started throughout the territory, where all our schools have been closed. Hopefully they'll be opening soon. Strict policies were placed in Nunavut to flying, and mandatory isolations were placed in hubs. Social distancing is placed in all places, public places, including the stores. There are no more than 50 people to gather in public places. I've been working with the TB program for about 3 years, and I am doing frontline work.
Thank you, and Dr. Cooper?
Yes, thank you. My name's Ryan Cooper. I'm one of the TB doctors in Edmonton, and I'm also work as a medical officer of health and the medical director for the provincial public health TB program. The lockdown situation in Edmonton and in Alberta is opening, perhaps distressingly so. We now have allowed more than 50 people to gather indoors. Weddings and funerals are open, as are bingo halls and casinos, but schools remain closed. It's nice that things are opening up again, but we are seeing in Alberta an increase in our COVID case numbers as a result, and I do believe now we lead the country in per capita COVID cases, and we're tied or close with for hospitalizations.
Hi everyone, I'm Aamir Khan. I'm based in Singapore, and that's where I was till April when the pandemic started peaking amongst migrant workers in Singapore as well. But then I moved came home to Karachi, where my family is for Ramadan, and have been here since then, and sort of landed from the frying pan into the fire, where we then sort of peaked here in late May and June in terms of the COVID pandemic, with all the lockdowns and everything else that was going on. So I've sort of experienced two different responses to COVID. One, which is led by a very strong central government, very proficient, but yet still they were affected by the fact that migrant workers in large dormitory settings were exposed, and then the bug spread like wildfire. And then in Pakistan, where the government, public, and even the private responses were, relatively weak, and we did see a peak, but then for whatever number of reasons, likely to do with transmission dynamics and the epidemiology of the disease in our population, we seem to have had a decline since then. So my role within IRD Global, which is the organization that I lead in Singapore, as well as here in Pakistan, has been with regards to TB to develop a lot of active case finding, private sector based programs. And we've had a lot of help from TB Reach, which is the Canadian government-supported initiative within Stop TB Partnership. And we're extremely grateful for all the learnings that we've had from that experience over the last decade. And I'll be speaking about some of that when I respond to other questions later.
Thank you so much. So Dina, over to you to moderate our panel discussion. I'll be here to support as you need.
Great, thanks so much, Ryan. So the first two questions I have for our panel is number one, what are the top 3 challenges you are facing in your TB work due to COVID-19? And number 2, what resources or solutions are needed to ensure continued provision of quality TB care and to mitigate the impact of the COVID-19 pandemic / lockdown? And we'll start with Dr. Ryan Cooper.
Thank you for these questions. I thought of the challenges that we faced here, and I came up with a list much greater than 3. Just I think the COVID pandemic has presented a number of stresses and a number of challenges. I suppose the one that's front of mind for me is on the stress on our TB workforce. I think several months into the pandemic, I think I worry that people will start to fatigue from information overload, from vigilance overload, from so many of the changes we've had to make to the way we take care of TB patients in this time of COVID. We've had a few workforce losses, not too many to diversion to other activities because TB has been considered essential, but people have had to take time off if they've been exposed and have to quarantine. Or if they have to self-isolate because they have symptoms that are concerning. So I'm pleased to say the staff so far is demonstrating resilience and cheerful resilience. So I'm optimistic in that sense, but I do worry about the long term. This pandemic is here to stay, and to be able to sustain all of this is going to be difficult. I think another thing that's stressful for me or a challenge I see in the future is how much of the economic disruption has really affected particularly some of our vulnerable patients. So just in the past week, there had been homeless shelters that have been temporarily set up to expand our capacity to house people. But as the economy opens up, those places were returned to their usual uses, and abruptly the homeless shelters were shut down. We're seeing increased substance use as evidenced by increased overdoses. And so I think that homelessness, increasing homelessness and the instability in housing and the increased substance use is going to be hard for our patients, and I think will make it difficult for us to treat TB. I think staff feel that too, if they have spouses who aren't working or if they have to stay home to look after their kids, that can also be stressful. And I think probably the third challenge is most directly relevant to TB control is we have seen, I think, a decline in LTBI treatment during this COVID time. We haven't seen a decline in the number of active TB cases we've seen, but definitely a decline in the patients referred to us for latent TB infection. And then we've also had to defer some of our treatment starts in this time of LTBI treatment starts in this time of pandemic. So I think those are 3 big challenges amongst many.
And then what resources or solutions do you think are needed to continue our quality TB care?
Yeah, thanks. I hopefully that our community can keep the case numbers down so as not to overwhelm our public health system for COVID, that we can keep up with contact tracing and notification. I do think we need to maintain housing supports and financial supports, particularly for our underhoused and underhoused patients and our vulnerable groups. And then I hope that there can be programs to support our staff, whether it be danger pay or additional mental health supports for our staff, so that we can maintain their resiliency during the long haul of COVID. And I think there are some resources that we could help make things more efficient. I think having more access to quantiferon to reduce the amount of time nurses spend doing tuberculin skin tests, would free them up to do other activities. And I think optimizing our ability to provide virtual health is always appreciated. So right now we've embraced virtual health a lot, and it's been really helpful, both in video DOT and virtual health in and virtual clinic appointments. And I think that's been really helpful for us. But we'd like to get better at it and include things such as asynchronous video DOT to help optimize nursing time.
Great, thanks so much, Dr. Cooper. And Dr. Khan, same 2 questions to you.
Thank you. So I'm going to focus on the situation here in Pakistan. I think early on in the lockdowns, the first challenge really was that the political response was so overwhelming in terms of locking everything down, that essential TB services and many other essential public health services were all in effect shut off or shut down, because there was this fear that if patients turned up at work or at hospitals, or even if healthcare workers turned up at work, that there was going to be transmission for COVID as well. So I think the earliest challenges we faced really had to do a lot with the fact that both patients as well as healthcare workers sort of disappeared from the health system. But then gradually they started coming back as people do fall sick, and health workers get better informed and get back into the proper protection suits and get back to work. And at that point in time, I think what we noticed, first of all, was this very rapid decline in the notification of people with TB. And that was resulting from the fact that there had been weeks of centers, especially public centers, that had just not opened up. So to a lesser extent, the private sector remained open, but the public sector, because of the government rulings, really shut down. And so these patients had no places to go. And we believe that's just going to lead to a pooling of prevalent cases in the community that hopefully, as the year goes on, we are going to be able to find with intensified active case finding approaches. I think the third sort of biggest challenge, I think, that still remains is the stigma associated with COVID, and the fact that we think that patient healthcare seeking behaviors are being influenced both in the public sector sites as well as in the private sector sites. So we are not seeing as many patients come in. The footfall, if you will, into hospital outpatient departments and private primary care centers have declined. And when that happens, you just have fewer people that you're going to be able to screen for TB or test for TB, and so you will find fewer patients. What I think we're going to need is a better strategy for integrating TB screening into what is the primary focus of the government and of the general public, which is the concern around COVID. And the more we can integrate them, the better, and more efficiently we can integrate them, the better testing options that we can offer patients. So if somebody's going to come and get a chest X-ray on a mobile van, if they can also get a rapid test for COVID antibodies, even antigens on site, that is going to be helpful, because what tends to happen is there are still limitations in terms of the total number of tests available for screening for COVID. And yet that isn't the case for TB, because before the lockdown, there were sufficient testing centers, there were supplies. In our instance, we've been using the Cepheid Gene Expert cartridges, and there wasn't a shortage of those, but there was certainly not all the COVID testing that we needed in our mass X-ray mobile platforms. And so I think better integration there would help. I certainly think that one of the key lessons from the political response is that you can get politicians interested in pandemics and epidemics when it matters to them. You can get the general public responding to pandemics and epidemics in a very different way than they respond under normal circumstances. So, I think a lot of populations, as with all the misinformation there is, but a lot of populations are now accustomed to, reading numbers of how many cases have been infected yesterday and how many cases have died yesterday and how many tests were done yesterday. And imagine, that in the TB world, where we're used to quarterly reporting. I mean, you've got whole populations and politicians now thinking, oh, well, how many tests did we do yesterday? And that's just not the way the TB community by and large has operated. So I think there are going to be some ways for us to sort of leverage that new insight into thinking through better coordinated, integrated COVID and TB responses.
Great, thank you so much for that. And Sharon, same two questions to you in your location.
Hi, some of the issues that we have faced during this pandemic here in Nunavut, one of the big things is the human resourcing. Nunavut is the only jurisdiction in Canada that does not have a single case of COVID-19, and we're so happy for that. And we have placed a lot of travel restrictions. Well, the government has placed a lot of travel restrictions as a public health measure to protect Nunavut youth from acquiring or passing along the virus. This has then impacted the amount of healthcare providers equipped with TB knowledge available to come to our communities to work here. And those who have expertise in public health care, and especially during this pandemic where most of our resources have been focused on COVID-19. Many long-standing diseases such as TB have been put on hold to focus our efforts on COVID-19. Although TB is still a very relevant issue and a potential threat to an outbreak in our communities in Nunavut. Another issue we faced in the beginning was getting people tested for TB. The health center had placed limited number of people going into the clinic, and this caused a slight decrease in the number of people getting tested for TB. So then our TB nurses had started doing home visits for most of their work, like doing TSTs, blood works, assessment, contact tracings. And when the restrictions were placed at the health centers, most of the TB-related workload are now being done at home. So when a TB nurse is doing a home visit, our clerk, interpreter, or our DOT worker usually follows to interpret. And this had caused the DOT worker or the clerk interpreter to fall behind on their own workload. Administrative work or other DOT work needed to be done. By doing more home visits, this caused a limited home visits being made because of limited transportations as well. So what resources or solutions are needed? Biggest thing would be needing more human resources here in Nunavut. And that would include TB nurses for hands-on care and to provide, so they can provide appropriate information about TB and the impacts of COVID-19 in a manner that is understandable, as there has been a lot of information shared on the virus. And we would need more DOT workers for such things as medication administrations and clerk interpreters for administrative work. That would be it for me.
Did we lose you, Sharon?
No, those were some of the issues we faced and some of the solutions we need to ensure continued provision of quality TB care in our territory.
Great, thank you so much for that. I see some common themes of human resources and facility resource issues in all areas that have been impacted by COVID-19 and TB. I'll start with the first question in the chat box, and then Robyn, you can let me know if people are raising their hands to ask questions. Malega, I'm going to not say your first name properly. Kojava Malega, do you want to pose your question verbally to the panel?
Okay, yeah, thank you very much. Yes, my name is Kojovi. I just wanted to know if there is any ongoing research that will evaluate the burden and the severity of COVID-19 on TB patients, because we all know that they have similar route of transmission. And is there any factor of exposure or protective related to their treatment, or just wanted to know? Thank you.
And we could probably take one more question from the audience before our speakers respond again, if anyone has another question.
Dr. Cooper, Dr. Khan, can you respond to that question?
Yeah, no, that's a good question. I think all of us think that TB and TB survivors and TB patients will be more vulnerable to COVID. I think there's a high pretest probability of that, whether it be from lung damage that has occurred from previous tuberculosis, making you more susceptible to bad outcomes if infected with COVID. And then some of the immune suppression that leads to TB might make you more vulnerable to infection. There is one preprint study that's very small that I'm aware of that has suggested that TB patients do in fact have worse outcomes with COVID, but the numbers were very small. I know we have had 2 patients that I'm aware of that have had COVID and TB, and both of them, for what it's worth, had mild illness due to COVID and recovered apparently without incident. I do not think that I'm not aware of any study showing that TB drugs would reduce your susceptibility to COVID or increase your susceptibility to COVID. And I wouldn't expect that to happen, those to be relevant. I suppose a small thing to consider, interact with dexamethasone, and if dexamethasone is used in the treatment of COVID, one might have to be aware of that.
So I'm going to just add, not in terms of scientific sort of publications or data per se, but there's a lot, of course, that's not known about co-infection at this point in time. It's very early for all of us, but just the experience we've had at the Indus Health Network here in Karachi, which has x-rayed since April 1 over 23,000 individuals that were screening people that were coming to sort of locations where mobile x-ray vans, where people presented with symptoms of COVID or cough or just wanted to get an x-ray. Now, out of those 23,000, they found almost 1,400 COVID cases amongst them. So these are RT-PCR confirmed cases, about 140 TB cases, and 6 of them were co-infected, meaning they had both TB and COVID disease. So as a if you were to sort of think about it from that experience, where it's not a screening of a general population, these are people who were self-referred to these sites. They got an x-ray and then they got either a gene export test or RT-PCR done if they had radiological signs or symptoms. You find a lot of COVID, you find a lot of TB, and there doesn't seem to be a lot of overlap. And I think the overlap that we do see in these 6 patients is likely to be just coincidental. However, I think what is required is that we begin to develop case series and start publishing the experiences, or what Ryan was just describing about his 2 patients. We would want to be able to sort of describe the severity of illnesses in our patients, some of the treatment outcomes, etc. So it's early times, but I think large-scale screening programs and potentially some research sites might begin to give us some early data.
Sorry, just before we move on, Joseph Egbuyu, I see that you're sharing your screen. Do you mind just stopping sharing your screen? Okay, thank you.
And then I'll just pose a question. I think everyone's raised human resource limitations in one of the challenges that they've experienced. I'm interested in how people feel we can best advocate to ensure that our human resources aren't redistributed during this time frame, because I think it's at least in my clinic, it's been a major challenge over the last few months.
Maybe I can start with that. So I think with regards to HR, human resources, in our programs in Pakistan, we have about 1,200 to 1,500 staff that are focused on the TB programs and a combination of the public sector and private sector sites across large parts of the country. And what we found was that we had to rethink the way they were operating. For one, in the beginning, all the hospitals were shut, yet we had to continue to supply medicines to all the patients that were on treatment already. We had significant populations of individuals, household contacts, who were on preventive therapy, and that preventive therapy needed to be maintained. What got shut, in effect, was all the teams that were out conducting active case finding, in our instance, principally with mobile chest X-ray vans. And so we then rededicated them to the government public sector responses towards COVID, because that's all the government wanted to listen to in the beginning. And then over time, incrementally, got permission for them to reintroduce TB screening and testing services. So there were large parts of the time when a lot of our HR was homebound, but other teams were pivoted very quickly. So our mental health counselors and contact tracing teams, in the beginning, again, they were housebound, and they shifted their in-person counseling and home-based contact tracing to phone-based systems. And so it was a very different way of them operating. Everybody was at home using mobile phones. And so instead of, so we started topping up their, mobile phone services at charge. And I think people have, by and large, figured out how to make use of the health workers that they have. But I do think when you have these spikes and you have these surges, there is a tendency for staff to be drawn into the COVID response, and that will impede the quality of TB care that we provide.
Great, thank you. And Sharon, I know in your location, there's very specific challenges, especially with relying on healthcare providers that have to travel in. So what things have worked with your team in trying to continue your work?
Our supervisor has been doing such a good job recruiting. That's the biggest thing, recruiting nurses to come up during this pandemic. So we will be hiring 2 more nurses during our little outbreak that we have right now with TB. So it's all about our supervisor getting people to come in to Nunavut.
And they've been responsive to those requests?
Yes, they have been. They're willing to come up and come work with our program, and they're responding well.
That's great to hear. So I think just in the interest of time, we'll move on to our next 2 questions, and we'll ask Dr. Khan these questions first. So the next question is, do you see any opportunities in the changes to your TB work because of the COVID-19 pandemic? And then the second question is, how have TB programs adapted during the COVID-19 pandemic to be able to continue to deliver services? And I think you touched a bit on that with the last question, but if you could expand on that, that would be greatly appreciated.
So maybe, again, to acknowledge the incredible support we've had from TB Reach. And so if there's any real opportunity here, I think it's the TB Reach history. Our group has received several of these grants over many years in many different countries. And what we've learned is that you always need to innovate when you are, when you're in these difficult situations. You need to be able to pivot your approach, your teams, to new ways of thinking, and that's not always easy in the TB community because a lot of systems have been built previously top down. And so I think the culture that TB Reach has helped many teams like ours around the world, imbibe, is a really excellent one to bank upon in these very uncertain times. And I think the focus that the politicians have on infectious diseases, on airborne, particularly airborne disease here, really should also help us highlight the fact that in the background, there are, in fact, more people that die from TB than die from COVID in almost all of our countries. And so why is this level of intention, or this level of attention, or some sustained level of attention, not available to what is essentially a public health emergency in non-COVID times as well? And I think the political advocacy focus is really important. I think the opportunity to innovate, I would hope that subsequently as TB Reach continues, and other funding mechanisms from within the TB community, that they really allow for a lot more space for innovation and thinking through responses that are not the same as we've done things before. So I think a lot of that is going to be useful. I do think in terms of the health system adapting and the TB response adapting to the challenges, this isn't going to be easy. I wish I wish there was like a surge and we were over with it. It isn't going to be that, even if different countries are at different points, experiencing these waves and wildfires, if you will. I do think we're going to be in this for the long run, so we're going to have to adapt to systems whereby at some points in the year, our focus will divert back to the COVID response. And yet, unlike the first time, we should be able to maintain some minimal level of TB care in the health system, both the public and the private sector, so that we don't see these very rapid declines in notifications, over 50% in the city of Karachi in Q2 of this year. And so, that is not something that we need to have repeated. We should be better prepared. We should be able to keep minimal TB care services running even during the peaks and surges.
Great, thanks so much for that. And if everyone can make sure that they're muted, that would be great. And Sharon, I pose those same two questions to you.
Thank you. What opportunities we see, hopefully this would provide some of our higher burden communities in Nunavut with ideas on how other TB programs conduct their DOPT programming, and if there could be some new ideas and discussions on how we can care and treat our TB clients as we see through the midst of the pandemic. It would be great to see how other high burden nations have balanced their TB care during this crisis, and how have TB programs adapted during this COVID-19 pandemic to be able to continue to deliver services. Is that we have, like I said, we've had increased our home visits to do TB testings, and from those visits we've seen more appointments made for TB investigations, and we have applied for overtime when needed to complete our work, whether it be for assessments, TSCs, or DOTs. And many of our public facilities and government buildings in Nunavut were closed to the public during the height of the pandemic and are just recently opening up. So because we are the only jurisdiction in Canada that has not seen any cases of COVID-19, we had to adapt to many of our services being provided for the public under the health protection orders made by the government to ensure that any community transmission is not occurring.
Great. Thanks so much, Sharon. And Dr. Cooper, same 2 questions to you.
Yes, I think we've had to make a lot of adaptations in the face of COVID, much of it around allowing for physical distancing and healthcare worker protection in the workplace to accommodate be prepared in the event that COVID infected individuals attend clinic. We've had a couple of active cases, as I alluded to before, but we've also had a number of patients who have been identified as contact of TB and who we're trying to evaluate for preventative therapy, who have also found that they've had COVID, whether asymptomatic or not. So really, some of our adaptations of including ensuring that our clinics are robust to any potential exposures, acknowledged or not. I alluded already to the importance of virtual care and how we're all getting better at that. I was such a Luddite pre-pandemic, and I feel I'm a millennial again with my increasing savvy with technology and how to best provide care for patients. So I'm grateful for those things. I think the COVID presents a lot of opportunities, and I think people are now in government are mindful of the need to monitor, as we like to take that opportunity to increase our ability to monitor LTBI care. Right now, we're grateful that active TB cases are still being found, our rates are maintained, and we have good monitoring of active TB in place already. But latent TB infection, I know anecdotally, and when I look at our clinic appointments, we're seeing a lot less of preventative care in our refugee populations and a lot less referrals for migrant groups and medically immunosuppressed groups. And I think this is an opportunity to monitor LTBI care better, to have proper cascades of care that are in real time, that are monitored regularly, so that we can give that feedback to our funders. Because of course, although the LTBI preventative therapy declines we see now probably aren't making an immediate impact, but we know that there's going to be a backlog as we try and catch up to them later on. And then of course, if we don't catch up to them, they may progress to active TB, or they will progress in some cases, and that's going to make things worse. So I do see an opportunity to improve our data monitoring. I'm also seeing opportunity I see that the COVID epidemic is educating the public about the importance of contact tracing and prevention of disease, as opposed to, we're starting to see a shift from how do we treat a disease to how do we prevent it. And in COVID, I think that's necessary because we don't have good treatments for it. And so I think there's an opportunity to remind people that TB is the archetype of how you can prevent disease, and how important contact tracing is, and active case finding and isolation is. So
Great. Thanks so much, Dr. Cooper. And so the first question we have is from, I've lost it here in my chat box, from Zylan Wee. If you'd like to pose your question verbally, that would be great.
Okay, thank you very much. So my question is regarding about how to improve the TB case funding, and in other words, how to really make the integrated COVID and TB care together. Because, for example, in Pakistan, I can also see in the box chat in Nigeria, they're using the mobile teams to reach people and to do the digital X-ray screening. Or in Pakistan, they do the the gene expert test, etc. But at this time, we also probably need to test people both for COVID and TB. The second thing is that both providers and patients might be afraid to come for this kind of active case funding because of the fear of they may be infected with COVID, they may be COVID rather than TB, etc. So I wanted to get experience from the different places, how we are looking forward for the innovation of really kind of integrated TB and COVID care for the future.
Thanks, Jolene. I saw you've addressed the question to me. I will point out two aspects of this. So there's, when you're looking for TB patients with TB, there's active case finding or active screening, but there's also this contact tracing piece, and Ryan just touched upon this, and I think they're both really instrumental in helping us find patients in these very difficult, situations where patients are not willing to come to large hospitals. So what we do note is that while patients are not willing to come to facilities, if you set up mobile testing sites, these drive-throughs and walk-throughs and all these examples people have used for COVID, people are much less afraid of coming to these kinds of screening and testing sites. And so most of our screening that has happened to date has in fact occurred at these sort of specialized treatment sites or at these specialized hospitals where on the premises we've been able to offer sort of standalone screening services. The other aspect of where patients are being found, really, it has been with contact tracing. So onto active case finding with regards to chest x-rays, Eno from Nigeria speaks about the fact that there are now AI-enabled software that will screen for certain aspects of pneumonia that are associated with COVID disease. So the experience that we've had using software, both chest x-ray AI enabled software, both for TB as well as for COVID, is that the use case in TB is very clear. If you have a lot of people that have asymptomatic disease, but yet you have radiological findings associated with that asymptomatic disease. That isn't in fact the case with COVID. So for using mass X-ray screening, we can increase by 3 times the number of TB patients that we are able to find because a lot of them are asymptomatic or early on in their disease, and you can find that on X-ray. And if you get a gene expert test done, you find these TB patients. With COVID, in using the same software we're using, in fact, in Karachi, we've been piloting the Cure QXR COVID software, and we have seen a 10% sort of increase using that software because everybody else who was found to be symptomatic. They would have been tested for COVID disease anyway. So the actual, increase is about 10% relative to, in the case of TB, where you can find 3 times as many more patients by using chest X-ray screening. So I think the use case still has to be thought through with regards to COVID and chest X-ray screening. I do think that as Ryan pointed out, the public and politicians are talking about contact tracing, and that's something that you wouldn't have imagined 6 months ago. And contact tracing, I think, is now going to be fundamentally the way where the integration of TB as well as COVID case finding is going to be much better served, and perhaps better served with rapid testing. So of course, with TB, we would need to get them out to a rapid molecular test generally. But for COVID, if there are rapid antibody or antigen tests that can be done on site amongst household contacts of patients that are otherwise index cases, you can imagine that strong, robust contact tracing is going to result in a lot more, additionality or addition of cases that are notified to the public sector. So I do think there are use cases that are best suiting TB with regards to the chest X-ray, and perhaps rapid diagnostics and contact tracing with COVID, but both should be done and both should be integrated for both COVID and TB.
That's great. Thank you so much. And I think that leads very well into the next question from Petra Hetkamp, if you can go ahead.
Yes, hi, thank you. Thank you for taking my question. And I'm really pleased with this explanation, Aamir, because that is exactly the kind of answer that I was looking for. Working in the TB PPM Learning Network, we specifically are interested in engaging the private sector. And I know in Pakistan that is a big, obviously a big sector. And I know your work with IRD is excellent, and excellent examples in those regards. And I was actually wondering from the Canadian perspective, I was listening to Ryan, really interested to hear the stories about how we, in a sustainable pandemic, can really look at the resilience of the healthcare sector, ensure that healthcare workers are supported. And looking forward, when we think about using this pandemic, it's good to hear so many good examples of the opportunities that COVID provides. And I would be interested to hear from the Canadian perspective as well, is like, how can the TB services really, private sector is not so relevant in Canada, but still it is. How can we really ensure that we're going forward and building a system that is better for everyone and involving communities and is really people centered? So I appreciate all your thoughts. Thank you very much.
Yeah, thanks for that question. I definitely agree with you on the importance of that question, but I think it's a very difficult one to answer, and so I don't claim to have all the answers. But I do think there's evidence that our communities are sympathetic to the struggle that healthcare workers are undergoing, and I think we need to harness that. I think there's also a sense of generosity of spirit. In Edmonton, we had a 50-50 at our hockey game that raised $12 million, which is an absurd amount of money. But that went to the charity supported by the hockey team. But I think there is an opportunity to, I think, increase funding support for healthcare workers. I know that healthcare workers signed up for things like this. I know I did. I'm grateful for the opportunity to be able to serve and to be able to help. But I don't know that most healthcare workers signed up for such a sustained hit to their well-being. And there's so much uncertainty about whether we're going to have supplies of PPE in the future or supplies of the drugs that we need to treat patients. There's so much. I know I'm uncertain whether virtual care is actually good or bad. There's been lots of, our scientific advisory group for the COVID pandemic here in Alberta has been trying to examine that question. There isn't really a lot of data, and so that's also another stress. Is our efforts to employ virtual care to protect, to help see patients, avoid healthcare contact, but also allow us to carry on with our work. Is that actually useful? I don't know. And so I think being able to be better at virtual care, because I think it's going to be necessary, but also understanding where it fails us in a more scientific fashion will be useful. And yeah, so we signed up for this, I know, but I think extra, like danger pay effectively would be, I think is necessary, maybe in the form of increased breaks, or time off, especially as the obligations at home increase with schools being closed. I feel like I could go on, but I'm going to stop. That's such an important question, and I appreciate you asking it.
Thanks so much, Ryan. And I'm going to take the moderator's prerogative and ask the last question. And I'm going to pose it to both Robyn and Sharon. And I think Ryan and both Aamir touched on it very clearly. We already have a lot of divides in our care of our patients. And one of the things I've noticed is virtual care is something we've all gone to, but there's patients who don't have access to that. Some of our rural patients, some of our northern patients. And I'd like if Sharon could speak to it, and Robyn specifically, as we advocate for resources and continuing TB care, how do we best advocate to ensure that all of our patients have access to the virtual care that they need, when we know, specifically in Canada, I would assume in Pakistan, but I'm interested in Aamir's thought. And I know up north in Canada, people just don't have access. That's why certain people are joining via telephone today.
Sharon, how about you go first, and then I can wrap up to conclude our session.
So how do we advocate for people up north?
To have the resources, I mean, I'm joining without video because I don't have a video camera. We don't have enough video cameras in my hospital to do so. I know you're joining by telephone because you don't have enough access to do so. And I think that it's important that we try to advocate that all of our patients have the same level of access to virtual care. And I was just curious how up north you think that we could assist with that.
Getting the federal government involved, to provide funding. Everything up north is very expensive. Like if I were to have a computer, another problem would be the internet and slow connection. So it would be a big problem. even just to have video access. So I think we would need more funding from the federal government, from the higher ups, to provide us with funding for proper technology, even if it's not for video conferencing or anything like that. It would probably be including general equipment for our health centers across Nunavut. Does that answer your question?
Yeah, definitely. I think we constantly need to be asking our governments and telling them what our resource needs are and why it's relevant that we are all equipped to be able to get online to join virtual engagements like this. Yeah, it's a little setting that Dina and Sharon weren't able to have their videos on with us today, which decreases our connection as humans and our ability to engage with one another. So constantly advocating for those sorts of things and elevating our needs is really, really critical and important. So thanks for sharing that experience, Sharon. So just in the interest of time, we are 4 minutes away from the close of our webinar session. On the topic of advocacy, it would actually be really great if everybody on this webinar right now that has access to Twitter could copy and paste the tweet that I just put in the chat box that says, "At home and abroad, we must ensure TV services are continued amid the COVID-19 pandemic. Disruptions will mean a resurgence of TV deaths and a reversal of years of hard-won gains." At Patty Hadju, who's the Minister of Health, at Karina Poole, who's our Minister of International Development, and at Mark Miller, who's our Minister of Indigenous Services. The at Stop TB Canada community calls on you to take action. So just copy and paste that and put it through your Twitter channel right now, and that would be awesome. And somebody is sharing their screen. Okay, great, thank you. Another important thing is we need to build community. Like now more than ever, we need to be pooling our resources and coordinating to maximize our impact. So part of the whole effort around relaunching and rebuilding the Stop TB community is to do just that, is to bring us together and amplify our voices and have a bit of a rallying cry so that our government decision makers and influencers and others in positions of influence know what our needs are and know that we have a strong voice that should be heeded. So on that note, I think we should give a very big round of applause to all of our brilliant speakers who joined us today. Thank you so much. Dina, thanks for your great moderating. Just to note, this is just the first of many webinars to come through the Stop TB Canada network, and we'd be pleased to collaborate with anybody who wants to host one through our channel in the future. Just get in touch, we'll make it happen. So round of applause. If you can use your reactions function in Zoom, there's a reactions function, just click on it and select the clapping hands function. I'm sure everyone would appreciate it. Thank you so much. We will be in touch. We have recorded this session. We'll try and share it widely with everyone. And I will stick around for the next 5 or 10 minutes or so if anyone has any questions about any of the relaunching of Stop TB Canada website, Twitter account, or the steering committee. I'll stick around to take any of those questions. We were going to do some final remarks from our speakers, but we're out of time. So I might follow up with you each individually to get a inspirational quote from you that we can share out through social media, if that's okay instead. Any final words, Dina?
No, I'm just really thankful that we could all join together and appreciate everybody who participated and our excellent speakers today.
Great, thanks everyone.
Thank you, everyone. Bye-bye.
Thank you.
Thanks so much, Sharon. That was brilliant. Thanks so much, Aamir. Such a pleasure to hear you speak.
Thanks so much, everyone. It's so greatly appreciated.
Yeah, we had like 100 people on it throughout most of the session. So I think that means we reached our capacity because only 100 people can join at a time. So I have a feeling some people might not have been able to get in.
Okay, thanks again, Robyn. That was so smooth. Well done. That worked really well. No Zoom bombs.
Only a few unmuted people and screen shares, but I think we think it went quite smoothly considering we had 100 people. So thanks so much. And with you in the car, it was flawless.
Thanks.
Yeah, nice backdrop.
Yes.
And Sharon, I'm really glad it worked out to call down. That was wonderful having you.
So Dina, I'm just going to stick around in case anybody has any questions about anything for a bit. All right, unless anyone has any questions about Stop TB Canada as a network or any of our relaunching activities, I will close the call.
Thanks, Robyn.
No problem. All right, bye everyone.